Hello, students. Welcome to chapter 17, Concepts of Care for Patients with Allergy and Immunity Conditions. This is part 2. We were talking about systemic lupus erythematosus. And now we are going to review all the information related to laboratory assessment. So this condition cannot be diagnosed by one type of laboratory testing. We need multiple tests, right? Because remember, we were talking about that the condition probably is going to take up to 54 months from the first symptom all the way with the slow progression to present with multiple symptoms. So the doctor is going to have the full variety of situations in order to refer the patient to the rheumatologist, right? So remember, we have chronic fatigue. We're going to have low fevers from unknown origin, right? And then we are going to have this butterfly rash that is going to be appearing after sun exposure, joint pain in joints, and it's going to be systemic, and most of them, they are going to be bilateral. So all these symptoms can be misdiagnosed, and maybe the doctor is going to start treating some other causes, but it's not going to have any idea that lupus is present already. So that's why laboratory has to be extensive, right? Additional tests that may be used include ESR, which is your erythrocyte sedimentation rate, and your C-reactive protein CRP levels. And as I explained in class, you know that ESR is basically your Western sedimentation rate that measures how quickly red blood cells drop or create sediment in the test tube, right? So that's the difference with CRP, which is a protein that your liver creates in response to inflammation, and the levels in your blood increase when your body is inflamed. So basically, CRP is more accurate in terms of assessing inflammation. Other diagnostics assessment during SLE are going to be checking your kidney ultrasonography, right? The doctor is going to order images, and maybe CT scan are performed if the patient has abdominal pain or suspecting gland disease. Probably an MRI can be performed if focal neurologic deficits or cognitive changes are noted. Okay, then we are going to move to interventions. Patient with SLE is going to take acetaminophen and NSAIDs that can moderate daily joint and muscle pain. The most important is that acetaminophen, your Tylenol, can alter pain perception but does not reduce the inflammation. Remember, your NSAIDs stands for non-steroid anti-inflammatory disease drugs, right? So it's better your NSAIDs. So, but in this type of conditions, we have to do a trial to see which one works best for the patient. Also, corticosteroids are already part of the patient SLE drug management routine, and the dosage is increased and then tapered to the patient's usual dose when the flare is over. Remind the patient taking an increased dose of prescribed corticosteroids to precisely follow the tapering schedule and not to suddenly return to the base dose to prevent adrenal crisis. And we know the adrenals are located on top of the kidneys, and they are the ones that are releasing glucocorticoids and mineralocorticoids, right? So we don't want to cause a problem in the adrenal. SLE, some states recognize this disease, SLE, as qualifying eligible condition for a state's medical cannabis program. So there you go, there is another type of treatment. So far we mentioned acetaminophen, NSAIDs, corticosteroids, and then the probability of the cannabis. Getting, most important is to get proper rest and avoiding stressful situations that may induce a flare from family, finances, psychological issues. You need to work with the patient in terms of follow the best stress management possible. Probably a low impact activity that can keep joints flexible when preventing cardiac complications. And sunlight exposure should be minimized, and patient must be taught to wear sunscreens and protective clothing such as long sleeve shirts. Moist heat can reduce muscle and joint pain as well. So warm bath and showers or the use of spa tubs can be especially helpful. And this is good to know. Patient education and NCLEX alert. So all of these points are are points that you need to manage. So you know your SLE patients are going to have problems with the sun. You need to teach patient about this, how to prevent this situation, the butterfly rash, right? We have to prevent chronic fatigue by engaging in non-pharmacologic self-care, which is very important. Fatigue associated with SLE is chronic and often occur at the point in life when adults are expected to be most active and productive. So it's going to be kind of frustrating for this type of patient that they have to delegate. They have to learn to delegate multiple activities, right? To other family members, right? Maybe recommend ways of conserving energy that may include allowing other family members to cook or clean or, perform other physical activities. And here is the list of laboratory profile that usually the doctors are going to order for diagnosis SLE, systemic lupus erythematosus, your RBCs, right? Your complete blood count, and also sometimes we are going to see the decreased MCV, your mean corpuscular volume, in case of iron deficiency anemia. Very important. Also, the doctor is going to order a CBC with differential, right? And we are going to be able to compare your neutrophils, lymphocytes, monocytes. Do you remember I told you the mnemonic nurse love to monitor? So there you go. You have your first three, and then you have your eosinophils and basophils, right? So decreased overall white blood cells can indicate leukopenia, and then increased monocytes can indicate chronic inflammation disorders, and increased eosinophils can be present in autoimmune disorders. So this is extra information for you nurses, future nurses, to understand your lab results, right? Master this information. Your serum creatinine is the best marker for understanding renal damage. Also, the doctor will order your ANA, which is anti-nuclear antibodies, and is going to be increased when antibodies are present. This test is not used alone to diagnose SLE, but also is going to be used with other tests that we are mentioning right now. Your urine analysis with sediment test, they are going to look for RBCs and urine protein to creatine ratio. So this is basically, you don't have to memorize these, but whenever you have a patient with SLE and you are able to see the blood work, you're going to be able to understand, right? Patient and family education, avoiding fatigue associated with SLE, to choose activities that are most important to you and do those first. Shop online when possible to avoid having to go to multiple places. Give yourself permission to say no to activities that consume energy. And basically, this is going to be I strongly recommend you to refer patient to psychological advice, right? Counseling. So, because it's not easy sometimes to handling these types of recommendations without affecting right? Your mental state. Sometimes patients, they feel that they are not useful to do activities, right? Establish and maintain good sleep patterns and a healthy diet. And if you smoke, stop smoking, avoid nicotine in any form. Again, low impact activity, right? And stress building activities can improve endurance. Walking and stretching exercise are beneficial, and they are low impact activity, and somehow they can reduce the stress level. So preventing organ failure, as we mentioned before, the name is telling you about the condition, right? The systemic lupus erythematosus. It's important to follow your drug therapy, and lifestyle changes are the mainstay of treatment for inducing and prolonging remission periods, which helps to prevent or delay major organ damage, right? And then drug therapy often involves a combination of general and selective immunosuppressive agents, right? Because we need to stop the activity of the antibodies, right, that are attacking the system. Corticosteroids, we already spoke about this, is a systemic drug and is a general anti-inflammatory immunosuppressant. Common side effects that appear very shortly after starting corticosteroid, and this is good to know. You need to refresh your pharmacologic in terms of steroids, right? Acne, sodium and fluid retention, hypertension, anxiety, difficulty sleeping, and emotional changes such as crying easy. And then side effects with long-term therapy of corticosteroids include weight gain, fat redistribution, the very common moon face, buffalo hump between the shoulders, increased risk for GI ulcers and bleeding, fragile skin that bruises easily, reduced muscle mass and strength, thinning scalp, increased facial and body hair, increased susceptibility to colds and other infections, and stretch mark. And here the book forgot to tell us our hyperglycemia, very common side effect of the corticosteroids, right? And the disease and the drug will mask infection because it's really reducing inflammation, so an infection is not going to be present under the use of corticosteroids, right? So then teach patient about the long-term corticosteroids to never stop taking this type of drug abruptly. We know that that could be the first part in your teaching about corticosteroids. Do never stop corticosteroids abruptly, okay? Because we want to prevent adrenal crisis. If patient becomes ill and cannot tolerate the oral corticosteroid, teach them to immediately contact the rheumatology healthcare provider to discuss other treatment options. And that's good to know. Safety alert, all of these information in the safety box in your book are going to come in NCLEX. Remember, as nurses, they are going to test you basically in all the information related to safety. Now we have also antimalarial drugs such as hydroxychloroquine and chloroquine that are frequently used for SLE. Many patients experience remission while taking this drug, and hydroxychloroquine has immunomodulating and anti-clotting effects, which may be needed in patients with vasculitis to prevent thrombotic events. And remember, SLE also affects your vascular, right? Your blood and your arteries. So vasculitis is one of the symptoms, and hydroxychloroquine prevents clots, which is very good to know. The major complication associated with the antimalarial drugs is the toxicity to retinal cells, causing retinopathy that can lead to an irreversible loss of central vision. I would say these two factors is really mandatory that you remember. Hydroxychloroquine is very popular nowadays, even for patients that are going to travel abroad, okay, is the standard treatment that your doctor is going to prescribe in order to prevent infections when you travel to certain countries. So remember, it can cause retinitis, and also is good to prevent clots. Okay, so patients that are taking hydroxychloroquine, they need to have frequent eye examinations with visual field testing before starting the drug and every 6 months thereafter. This is in the case of patients that are going to take this medication for a long term, right? And then NSAIDs such as ibuprofen, naproxen, indomethacin, nabumetone, and celecoxib are used to treat pain and inflammation. These all medications that I just mentioned in different degrees are going to help with the inflammation. Low dose aspirin also can be used to prevent blood clots, and teach patients to take NSAIDs with food to prevent GI symptoms and to expect routine laboratory assessment to monitor kidney function. And this is something that many nurses forget about: kidney function related to NSAIDs. Okay, so that's good to know. Also, NCLEX alert: immunosuppressives such as cyclophosphamide, mycophenolate, formetil, oh Dios, oh my God. But the most important that I want you to remember is methotrexate. Okay, this is a very popular chemotherapy agent. It's an immunosuppressive, right? Are sometimes used to keep the body from attacking itself and remind patients taking an immunosuppressive that their risk for infection is higher because the drug is going to kill not only the good cells but also the bad cells. And we need to worry about killing the good cells, right? Our good soldiers. And they should avoid contact with ill people, because especially if they are going to be out of good soldiers, right? So wash their hands often and report any fevers higher than 100 degrees to the PCP. Now we have also the monoclonal antibodies, very successful with this type of autoimmune disorders. These drugs, usually given IV or subcutaneously, block specific pro-inflammatory cytokines that stimulate immune attacks. So the one that I want you to remember, belimumab, because this medication, it can be given by infusion and also subcutaneously, so you don't need to be in the hospital. Sometimes these medications are taught by nurses how to be administered subcutaneously, right? It could be done in the outpatient clinic. Infusion related reactions include severe hypersensitivity, and the drug must be given in a healthcare professional in a setting prepared to manage the possibility for anaphylaxis. So patients monitoring during infusion and for up to 2 hours after infusion, especially if the medication is going to be given in IV, right? So those are the medications I want you to remember. Again, let me review. I want you to remember all the information and precautions related to NSAIDs, your hydroxychloroquine, information about your methotrexate, which is an immunosuppressive drug, your monoclonal antibodies, especially belimumab, okay? And of course, we also need you to remember about the corticosteroids, right? So another safety priority, all immunosuppressant drugs reduce protective immunity to some degree. Patients who are prescribed long-term therapy with glucocorticoids should be taught about the potential for new infections and how to avoid them. Yes, because they are masking and they are putting your immune system to sleep, right? Somehow they are reducing the inflammation that way. And then lifestyle changes to manage SLE and prevent frequent flares. We have to work in the stress and to avoid exposure to ultraviolet light, especially sunlight, and manage the fatigue, right? So another safety priority, as you see, these type of conditions that are systemic and involve the participation of multiple autoantibodies, right? They have multiple safety, so that's important that you pay attention and focus on this. Instruct patients to avoid prolonged exposure to sunlight and other forms of ultraviolet lighting, including certain types of fluorescent light, even that. Okay, remind them to wear a long sleeve and a large brimmed hat when outdoors. Patients should use sun blocking agents with a sun protection factor of 30, and that's the important information here in this safety box. Sun protection factor of 30 or higher on exposed skin surfaces. Okay, and then the book is talking about home care management, self-management education, because the two most common causes of death among adults with SLE result from chronic kidney disease and cardiovascular damage. So first of all, let's remember that this disease is not fatal. They whenever they are diagnosed with SLE, they believe it's fatal. But if we diagnose the condition early and the patient is taking the medication, they can live, right, with all these precautions. Is treatable. So, but the two most causes of death are the chronic kidney disease or cardiovascular damage. So it's important to see the PCP regularly to identify changes early when management is most effective at preventing complications. So the key here is early management, early diagnosis, early management, right? You as a nurses, when you find somebody with chronic fatigue, the butterfly rash, the fever from an unknown cause, your arthritis, right, or joint pain, bilateral, that's something that you need to tell the doctor and suggest the patient to follow up with the specialist. So encourage low impact activity for short periods of time. We spoke about this. To refrain from smoking or using nicotine, stress the importance of protecting themselves from any sun exposure. So we cover this part. And then very important to evaluate outcomes is to adhere to the prescribed long-term SLE management. And I'm going to repeat this. This is a long-term SLE management with early diagnosis and early treatment, okay, in order for the patient to have the disease in management, right? And to reduce complications, have pain managed at a level they deem acceptable, maintain energy to participate in activities important to them, and experience longer periods of remission with low SLE activity. So we have concluded, right, this part about SLE. I'm gonna stop here because when we come back, we are going to focus only on HIV. Only on HIV. This is going to be, the next video is going to be a little bit long, but it's important that you manage this condition, okay? Let's stop here and thank you.